Welcome, everyone. We are very happy to have you here with us today on our panel discussion to discuss regulating cannabis for public health. My name is Rosalie Liccardo-Pacula. I'm a senior fellow here at the Leonard D. Schaeffer Center for Health Policy and Economics, as well as the Elizabeth Garrett Chair in Health Policy, Economics, and Law in the School of Health Policy and Management at the Sol Price School of Public Policy here at USC. I have a third hat as well. I co-direct the policy group within the Institute for Addiction Medicines here at USC. And it's the Institute of Addiction Medicine as well as the Schaeffer Center that are co-hosting this panel discussion today with generous funding and support from Richard N. Mencken Distinguished Speakers Series. And we are very grateful for that support. In today's program, we will be hearing from two excellent panelists, our guests, Ms. Rebecca Jessamine from the Canadian Center of Substance Use and Addiction, and Professor Ricky Blumenthal, who is Associate Dean for Social Justice and a professor in the Keck School of Medicine here at USC. Before I hand the panel over to both of them, I wanted to let you know we were going to have a few brief presentations highlighting some special topics related to regulating cannabis for public health purposes, followed by, we hope to be a lively question and answer period where you as audience members can submit questions at any point in time, and they'll go into a queue and we will be able to discuss them at the end of their brief presentations. So with that, let me say a couple more words about our guests today. We have with us, like I mentioned, Ms. Rebecca Jessamine, who's Director of Policy at the Canadian Center of Substance Use Addiction, and which is a national non-government organization with a legislated mandate to provide leadership and solutions to address alcohol and drug-related harms in Canada. During her 15 years with the CCSA, Rebecca has provided trusted counsel and expert commentary and presentations for all levels of government in Canada, and to law enforcement, educators, academia, service providers, and international policymakers. Her areas of expertise include cannabis regulation, alternatives to criminalization of drug use, and treatment reform. So she will be providing us some nice highlights of what the Canadian experience has been in both the medicalization and legalization of cannabis and some of their public health approaches taken there. In addition, we're going to be joined by Professor Ricky Blumenthal, who, as I mentioned, is Associate Dean for Social Justice and Professor in the Department of Population and Public Health Sciences at the Keck Medical School. Since 1991, he has been conducting community-partnered research on risk behaviors and health promotion among disadvantaged populations, so offers a very unique and important perspective on this topic. His current studies include an observational cohort study on the substitution of cannabis for opioids among people who inject drugs, an evaluation of Hollywood's LEAD program, and qualitative life histories of opioid use among substance-using men who have sex with men. But before we get into a discussion with all of that, I was hoping I could provide a little bit of background for those of you who might not be as intimately familiar with the current U.S. cannabis environment. So I am sharing with you just a few highlights to set the stage for our discussion today. Here we go. So in the U.S., since literally the 1970s, states have been experimenting with alternative cannabis liberalization policies ever since cannabis got included as a Schedule I drug in the 1970 Controlled Substance Use Act in the United States. Most of this liberalization policy was specific to possession and use through decriminalization policies. But starting in the mid-1990s, states began experimenting with legal supply chains, first for medical patients, trying to make it more available for use for medical purposes. And then starting in 2012 with legalization of cannabis use for adult purposes. As of June 2021, as this map is showing you here, there are 18 states that have fully legalized adult use cannabis for non-medical purposes, another 18 states that have adopted comprehensive medical cannabis programs regulated by the state, and another 10 states that have state-regulated medical programs but specific to low THC cannabis using products. So if you look at the U.S. states as independent jurisdictions, you'll see that the vast majority of states today have recognized both either the medical or the recreational value of cannabis in the US. This is all occurring under a federal prohibition, although that federal prohibition has finally being discussed and debated in our capital in Washington, D.C. In addition to a proposal passed by the House of Representatives in December of 2020, currently the Senate is now discussing a major initiative to legalize that has particular elements that are consistent with the House proposal. In particular, it removes cannabis from the Controlled Substance Act as well as its THC derivatives. It transfers the primary agency jurisdiction for cannabis regulation from the DEA to the FDA and provides them with similar responsibilities, some of them explicit and some of them implicit, for regulating like alcohol and tobacco, and it provides expungement for certain cannabis offenses and the call to remove cannabis from prison contraband so that we can reduce the ongoing criminalization of small possession and use of this substance. Both of these proposals, if passed, now they'll be discussing in both branches of our government, would offer major economic, legal, and social implications. And those have been the largest discussion, the social implications of these policies. But they also have significant public health implications. And that's what we were hoping to discuss today. While there's similarities in the House and the Senate versions of the proposals to legalize, one of the biggest sources of variation between the two proposals is in the level of taxation of cannabis. And it's not surprising, that former House bill was proposing a retail tax of, say, 5% on cannabis, and the more recent Senate proposal has a higher tax of 10%, increasing by 25% for the next 3 years afterwards. This discussion of taxation is a way of generating some revenue from the legal market to support the social equity programs as well as the public health regulations needed to incorporate this new regulated market. And the variation is not inconsistent with what we're seeing across the states. As I'm showing you here in this map, the states vary tremendously in the level of taxation imposed either at the wholesale or the retail level. The different colors are indicating whether or not a state taxes at the wholesale level and retail level, and the mid-green, or just the retail level, and the numbers are showing you at what level. There's only one state as of now that taxes cannabis based off of its potency. All the other states are taxing cannabis based on the weight of the cannabis sold or on the total market value. And that one state is Illinois, which has a higher tax rate imposed on the higher potency products, higher THC products. Now, both Vermont and New York are currently discussing taxation proposals that would be based on potency, but those are still ongoing in discussion. So taxation is an important element considered in public health discussions of cannabis, in part because they provide the revenue to support proper regulation, the testing and compliance of products to make sure that they're safe and effective, as well as reducing the use among high-use users. We know from alcohol and tobacco literature that higher taxes and higher prices are an effective way of reducing misuse of a product. But there's other tools that are already being implemented by the states. One of them are limits that are being placed on the quantity that can be sold in a single transaction. And what I'm showing you here on this map are the sales limits across the states for those states that had legalized as of January 2020. And it's focused on this sales limits for concentrates. And that's because all states except for two have the same limit of an ounce of flower material as a sales limit for anything that's bought as a flower. But cannabis is a very heterogeneous product. There's the plant, the flower and bud material, and then there's derivative products that get generated through processing of the plant, including oils, edibles, and concentrates. What I'm showing you on this map are the sales limits imposed on concentrates based off of weight across the states. And this is relevant to think about. Most states tax between about 7 or 8 impose a limit of 7 or 8 grams on concentrates. Those are the mid-level pink ones. Nevada has and several other states actually have a 5-gram limit on concentrates. And then you have Michigan, which has a much higher limit of 15 grams. These grams limits are important because concentrates, unlike flower, can have very high potency of THC. A colleague of ours, Stephen Davenport, who looked at data from Washington State seed to sale system, showed that the average potency of concentrates, the amount of THC in these products, is on the scale of 70% THC. That's average THC. Whereas flower material in the United States, the average potency is about 20% THC. The amount of THC is relevant because when we think about what is a standard dose of cannabis, at least in the edible market, the cannabis industry and states have come up with a standard 10 milligram dose for a serving of an edible product. So when we translate these sales limits into the actual number of 10 milligram doses of THC that can be sold by the limits, as I'm showing you here on the right-hand side now, these limits are actually translate into very large doses being able to be sold in a single transaction of cannabis, even with relatively strict rules on the number of grams of flower and concentrates being sold. Because the potency of concentrates in the US is not regulated and is quite high, no state has fewer than 500 doses of 10 milligram cannabis being set as a limit. So think of this as going into your regular liquor store and you usually buy a bottle of wine or a liter of more higher ethanol content liquor. This is substantially more than what we would be buying in any large dose. This is really wholesale selling, which is part of the reason why our current state markets have still been struggling with the black market. Another important aspect of regulation is making sure that these policies are adopted in a way that prevents youth access. None of the states have legalized the use of recreational or medical cannabis for children. And in a study that was conducted by a colleague of mine, Yun Shi, and myself, she did most of the work. She did an inspection of over 700 dispensaries in the state of California to see the extent to which they were compliant with California policy to check ID. And while the vast majority of these were registered legal dispensaries in the state, vast majority, 96%, were indeed compliant with checking for ID, which is the great news. The more upsetting news is that 85% of these dispensaries didn't check the ID until they were inside a waiting room for cannabis. That wasn't the store. That's where they would wait before they got released and their ID check to go back into the sales room. But it's important because in those waiting rooms, there were signage and messaging that was appealing to children, products, gummies, candies, cookies that might appeal to children. And children are allowed into the waiting room for those places that do not check the ID outside of the building. In addition to child appearing items, there were also signs, posters, and ads inside these waiting areas promoting the health benefits of cannabis, which, as many of us in the scientific field know, there's limited real knowledge of the health benefits as well as the health harms. And so exposing children who are in these waiting rooms to positive messaging can encourage the use of these substances. And this is an area that is important for the federal government to consider if thinking about legalization. So today, I'm very excited to be able to hand over the mic to a couple of people who have been thinking seriously about these public health regulations in the U.S. I'm going to hand it first to Ms. Rebecca Jessamine, again, the Director of Policy at the Canadian Center of Substance Use and Addiction. Rebecca?
Thank you very much, Rosalie. So thanks for having me here today to share a little bit about legalization of cannabis in the Canadian context. In Canada, legalization happened at the federal level in October 2018 through the Cannabis Act. Before we start getting into the details, I always think it's important to look at what the legislation is intended to achieve in order to evaluate its success and impacts. basically in terms of the objectives, then preventing young persons from accessing cannabis, protecting public health and safety, deterring criminal activity, and reducing the burden on the criminal justice system. The mechanisms through which we are hoping to achieve those goals, we've set the minimum age in Canada to 18. The personal cultivation limit of 4 plants, public possession limit of 30 grams dried or its equivalent, and that's for personal possession in public. There is no federal restriction on how much cannabis you can have accumulated in the home, for example. Different product formats, we actually took an extra year before we introduced edibles, extracts, and topicals so that we could work through the additional regulatory framework necessary to get those through, for example, the Food and Drugs Act. The penalties vary widely depending on the nature of the offense. And one thing I'll draw your attention to is the restrictions on packaging, advertising, and marketing. So basically no appeal to youth, and advertising and marketing are very tightly restricted. You can see from the product packaging and product formats here, very monotone, plain colors. The yellow is the mandatory warning label. There's the mandatory THC marking. There's excise stamps. And there's strict limitations on what branding information can be provided and how big any brand stamps can be. We have also imposed THC restrictions. There's no strict cap on percentage, but there's similar to what Rosalie discussed, limitations on the grams of THC in a given package that varies according to the nature of the product format. So in Canada, the federal government provides the legislative framework for what's legal and what's not, and is responsible for production, licensing, and compliance. Responsibility for retail sales and distribution is divested to the provinces and territories, so the equivalent of states. The provinces and territories can also impose additional restrictions provided they don't frustrate the intention of the federal legislation. We'll come back to that. Responsibility for enforcement really falls across both provincial, territorial, and municipal levels. And municipalities are also responsible for things like zoning and any additional bylaws related to cannabis. In some provinces and territories, municipalities can also opt out of having retail sales located within them, although there is online sales coverage across the country. In terms of taxation, the excise taxes are paid by the producers to the federal government. 75% of the excise taxes goes back to the provinces and territories. And the tax amount varies depending on the type of product. So dried plants and seeds, it's either $1 a gram or 10% of retail. And oils, edibles, and extracts are actually varied according to level of THC, so a cent a milligram. There's also a federal sales tax at 5% and provincial and territorial adjustment rates, which most provinces have added to the federal taxation levels. So I mentioned that the provinces and territories could impose additional restrictions. One, I'd say the most common variation there is age. So in Canada, the legal drinking age is 19 in most provinces and territories. So most provinces have raised the legal cannabis age to match that. The exception being Quebec, which has actually gone to 21 for cannabis, although the legal drinking age in Quebec is 18. And both legal drinking and cannabis age is 18 in Alberta. It's important to note the distinction between the federal here. So the federal government strategically placed the limit at 18 because that way anybody who is 18 will not, although they might be subject to provincial civil penalties, won't be subject to federal criminal justice penalties. So that's in line with the objective of reducing criminal justice involvement. Some additional differences, 2 provinces have prohibited home cultivation, and this is actually being challenged in the courts in Quebec at least. As I said, the provinces have some freedom, but they can't frustrate the intention of the federal legislation. So what's being tried in the courts is whether the prohibition on home cultivation is doing just that and going a bit too far. There's also home possession limits in BC and Quebec. Those have yet to be challenged. In the interest of public safety and preventing youth consumption, Quebec has placed additional restrictions on edible flavors and formats that would appeal to youth. And primarily with the concerns about vaping-related lung illnesses, 3 provinces have also placed restrictions on vaping products. The retail model is probably each province has its own focused retail model, but they fall into 3 primary categories. The private model, public or government operated, and hybrid. For hybrid, you're usually looking at privately operated retail stores with government operated online sales. Although in the context of COVID, governments have been permitting more privately operated online sales as well. This is just a quick snapshot of the number of storefronts. The pink indicates private retail. BC is kind of a pale pink because its retail storefronts are both privately owned and publicly owned. And a quick glance at the numbers kind of illustrates that the publicly operated stores were able to get up and running a bit more quickly and have been more stable. Some of the reason for the speed of implementation is because they didn't have to go through the same private licensing systems. But you can see that once the licensing systems got underway, the private store numbers have certainly increased. Looking at Ontario, for example, the huge explosion is associated with the lifting of a licensing cap, and actually the setting of a goal of allocating at least 30 licenses a week in Ontario. So if we look at what that translates to in retail sales, the blue line at the top is Ontario, where we've seen the great increase in the number of stores. So that's not surprising. Second line is Alberta. Again, not so surprising, another private retail there or private retail model that has opened a lot of stores. And then the pink line is interesting because that's Quebec, and they tend to actually have lower rates of use, a publicly operated system, the higher minimum age, and lower price point for some of their product. In terms of some of the challenges of the federated model that Canada has adopted, money is always the biggest challenge when you have a combination of federal and provincial legislation, and the federal legislation is really setting out the framework. Who foots the implementation costs? The provinces are dealing with costs that are associated with inspection and enforcement, impaired driving detection, and health interventions such as treatment. And there's really limited resources available at the federal level to do the types of inspections that some of the provinces would like to see, particularly in terms of the inspections for non-compliance with production facilities. The timelines have certainly been a challenge, and I know that we've seen this in the States as well. When the Cannabis Act was passed in June 2018, and put into place in October, that really only gave the provinces and territories about 4 months to set up the retail sales and distribution networks, coordinate supply, hire staff, do the licensing, and open the doors. So there were some significant delays early on, and also some challenges with supply. In terms of clarity and consistency, the patchwork approach is, from a research perspective, a wonderful natural experiment, but it can also make clear public messaging quite different, and it can make it difficult for people who are trying to navigate the system to understand the complexity between the different provinces and territories, particularly if you're operating at a federal or national level, like producers, for example, who might have different sales facilities in different provinces. Consistency of purpose is also a bit of an issue because the provinces and territories, with their focus on retail sales, are more interested in the revenue generation, where, again, the federal legislation does not have revenue generation as one of its objectives. In terms of data, there is actually a fair amount of data available in Canada. We actually have our National Statistics Agency has put online a national stats hub for cannabis, where you can get all the numbers about cannabis that the federal government is able to share. But there are some key gaps at the provincial and territorial level that would be useful in evaluating the impacts of the natural experiment that we have. So some examples of that are availability of data by month for retail sales, and also broken out by product type so that we can better understand the patterns of use. And there's also a time lag to being able to access health and criminal justice system data. And of course, the impact of COVID on any trend data is yet to be determined across the board for any retail or health data collection at this time. So in terms of some of what we're seeing, just very quickly, some increases in rates of use, both current use and daily or near daily use, which is of course of a bit more concern in terms of potential harms. And we're also seeing a closing of the gender gap, which is interesting. However, if we look, going back to the objective of reduced criminal justice involvement, such a drastic decline in cannabis possession charges, which of course makes sense, given that it's now legal for adults, but even for youth, we're seeing that decline. And as well as a decline in the cannabis source. So we're seeing more people purchasing from the legal market, fewer people purchasing from the illegal market. So the trend's heading in the right direction. We didn't think it was going to happen overnight, and realistically, the illegal market will probably never be completely eliminated, but we're pleased to see things heading in the right direction. So in the interest of brevity, I will leave it there. Invite you to check out an event we're hosting if you'd like more information, and don't hesitate to contact me at the information you see on the screen if any of your questions aren't answered during the Q&A portion of today's webinar. Thank you very much.
Thank you so much, Rebecca. And briefly, right while I let Ricky set himself up, there was a question in the chat about whether there's any child-proof standards in Canada. There are concerns here in the US about children getting into the family supply, and we have seen emergency department visits because of it.
So there are child-resistant packaging requirements for all of the packaging. Yes, and we are monitoring emergency department visits. Unfortunately, another data gap is whether the ED visits associated with edibles are from legal or illegal product.
Yeah, that's obviously an important question. Well, thank you very much. I'm excited to hand the mic over to my colleague, Professor Ricky Blumenthal, who, as I mentioned before, is Associate Dean for Social Justice in the Keck Medical School, who's going to be talking about the impact of cannabis policies for some vulnerable populations. Ricky?
Thanks a lot, Rosalie. Thanks for the invitation and the great talks. I always feel smarter when I hear you speak, so thank you for that. So I'm just going to talk about one special population in particular, which is chronic opiate users who inject drugs. There is some promise of cannabis legalization having impacts for this population, and so I'll provide some justification for why that's so important, then talk about some of the possibilities for the perspective of cannabis users, and then sort of look at some of the policy regulatory approaches that we might consider to maximize benefits for this high need and vulnerable population. And I'll try and do this quickly. And I won't get into too many details, but as we all know, North America, including Canada and the United States, are in the midst of an ongoing opiate overdose death crisis. That continues to increase in scope and loss of life. It's now driven by uptake of fentanyl use in both Canada and the United States. And there's also worrying signs of increased meth use, although that's just started to happen, where people like me and others are collecting data to understand the consequences of that on this population. There's also national epidemics of hepatitis C, particularly for millennials, and that's related to the uptake of injection drug use. We're in the midst of growing bacterial infection crisis in the United States from sepsis and infected endocarditis. HIV outbreaks keep popping up in the United States, and as I pointed out, we have these changing drug use patterns. And then lastly, related to the sort of the general tenor of growing income inequality in the United States in particular, we've seen material conditions for people who inject drugs worsen. So there's much more homelessness, much more food insecurity, much more exposure to violence, all of which make it more difficult for people to get help. Okay, so cannabis could be useful for this population a couple of ways. There's biological reasons, and now plenty of self-reported data that indicate that people do use cannabis to deal with opiate withdrawal, and sometimes as a substitute or a reduction of opiates. There may be other uses directly, particularly in relationship to cannabis use and medication for opiate use disorder, and I'll show you a couple of studies that show some promise in that area. And then there's things that we know less about, and I think our previous speakers really identified this as an issue, which is the new potency may create other potential impacts that could be of particular use to people who inject drugs. And of course, the idea here with cannabis is that if you're smoking cannabis and not injecting a drug, you're improving your well-being. So that's sort of the central premise of all of the things I'll share. So there's some evidence to suggest that where cannabis is legal, increased use is reducing exposure to fentanyl, for instance. That's the study on the left by researchers out of Vancouver. There's also some evidence that cannabis use was reducing non-fatal opiate overdoses among patients enrolled in methadone maintenance. Again, that's an important potential application of cannabis to the problems faced by this population. There's a work by Lake, and she's got a couple of papers out now, although this is all very new and we don't really know enough about how cannabis is being used in this population. But the key finding here was that they found that daily cannabis users had lower odds of illicit opiate use, which is important both for the reasons I've outlined, but also, we are experiencing these sort of uncertainties in the illicit drug supply, where you have people reporting using cocaine and it being contaminated with fentanyl. And so, any reductions in illicitly manufactured drug use is sort of a win given what's happened with the illicit drug supply. So this is some work some of my own work, and then Lake's continued work, where we looked at cannabis use intentions among people who inject drugs. This is data from 2016 to 2018. And the important part here was that we did, in the context of the fact that most people are still using cannabis to get high, there is a fair proportion of people who continue to use or report that they're using cannabis to help them with pain, anxiety, withdrawal, and even sometimes as a substitute for opiates. And a similar finding was observed by Lake and colleagues in Vancouver. There are big issues though with this in terms of, how do we get the cannabis for this use to these populations? This is a study I contributed to that looked at the distribution of cannabis. It's a qualitative study, but it indicated that there was a wide acceptance of cannabis by people who inject drugs, and that they saw it as being helpful in a variety of ways. Now, on the other hand, Lucas has this interesting report which suggested that enrolling patients in cannabis-related research might get more difficult in the context of legalization. And that's sort of an undercurrent theme of both the earlier talks and this one, which is, hey, if it's legal, it's probably safe. And we don't need to learn more about it. And I think that that's going to create some problems for us in the future. I feel like the way cannabis legalization's happened, particularly in the United States, is we have this sort of GNC model where it's loosely regulated and there are, unsubstantiated claims related to what it can do and not do for people. And that this might result in the fact that we actually don't end up generating enough evidence to support new medical uses for the population that I'm interested in. And then as it gets commercialized, there's of course a challenge, which is, it's hard to make money giving any medication to people who are very poor. And so, in my own work, we have substantial biomedical interventions that are really helpful to people who inject drugs, including HCV treatment, HIV pre-exposure treatment, and even the medications for opiate use disorder. And the access that my population has to those medications is quite low. I feel like that might be happening again with this cannabis legalization. So let me just conclude with a few thoughts. I do think more attention needs to be made to how do we ensure a safe supply. I don't know that fentanyl is ever going to contaminate the cannabis market. I doubt that. But there are many other things that could happen. And I do worry that, there's sort of this GNC model we've created for some reason, this carve out where a product can be made available to large numbers of people with little or no consideration of the safety. We're going to need resources to establish the efficacy of cannabis for medical purposes. And it seems like incentives for that are decreasing. And then if we do find that there are some useful applications, we're going to need a system of distribution that's effective for the population that I focus on. Thank you so much for listening to me, and I look forward to the discussion.
Thank you, Ricky. One question that I immediately thought of as you were presenting some of your findings, and I know you've done some work on this in the past, but I don't know if it's been recently. To what extent do injection drug users who are particularly vulnerable, struggling with homelessness and the like, purchase from legitimate stores versus black market sources, even now that we have them?
Yeah, I just looked at that question. We have information from about 250 people in Los Angeles and Denver, so both places where cannabis is legal. So about 2/3 of the people actually reported recreational purchasing at recreational dispensaries, which I was a little bit surprised about too, because in my earlier work, I guess, pre-COVID. We saw that there was increased cannabis use in this population, but a lot of it was coming from friends and family or acquaintances rather than from actual dispensaries.
That's really interesting because I thought I saw in some recent data from Canada, I believe it was from David Hammond's study of the international cannabis study, that he saw also that about a third of the household population in Canada was purchasing still in the black market. Does that sound correct to you, Rebecca? Am I remembering that correctly?
I would say probably about a third of people who are purchasing cannabis as opposed to third of the overall population. But
thank you for the
sure. And the other thing is we're seeing, I think, an increase. I'd have to go back and look at his data again, but an increase of people who are also purchasing from both. So they might not have thoroughly transitioned, but kind of dipping their toes.
So, Rosalie, sorry, I misspoke. I inverted them. I just looked at it because I was a little worried about that. So half of them got it from friends and acquaintances, and a quarter of them to the recreational dispensaries.
Okay. Thank you for clarifying. Because I think you're looking at injection drug users who are in 2 states with very large number of dispensaries is readily available. And an argument has been made by the industry that our taxation system has created a price differential that has led many people to be unwilling to purchase from legal stores and instead would want to buy from illicit markets still. And that's part of the reason why I was curious about the result as well in Canada, because Canada has not eliminated its black market, even with its well-conceived design. I mean, this is a thoughtful process that went through multiple iterations. Is there concern about purchases from the black market and the businesses being upset in Canada? Rebecca, is this an issue in your markets?
There's certainly concern. Again, I don't think anybody familiar with the operations of the illegal market thought that it was going to disappear overnight. And the fact that we are seeing transitioning, particularly early into the retail scale up, is a positive sign, keeping in mind that we didn't introduce the full spectrum of products until October 2019. There have been supply issues, licensing issues to establish retail stores. We still don't know what that magic balance is between, what is enough retail stores to ensure access that would incentivize purchasing from the legal market without incentivizing increased rates of use, that, balancing on a pin trick. And we also have yet to figure out what the impacts of COVID are going to be in terms of access via the retail market versus the illegal market.
Well, one of our participants has been waiting patiently, asked by Cody Peterson whether, in your mind, Rebecca, whether full legalization could have been done differently, what could have been improved on looking back now that we are here in the States considering federal legalization?
Always room to improve. And I think more time to implementation to allow for the scale up and allow the system to be fully ready would always be beneficial. And, again, we heard this from Washington and Colorado as well when we spoke to the folks there before we went ahead and legalized. I think some increased guidance to provide less of a patchwork. I think that there are limitations within the federated model to what the federal government can dictate to the provinces and territories from a retail system, but more clearly identifying what some of the best practices are in terms of licensing allocation and looking at outlet density limitations. I think that Canada could have also done better, in what we're seeing from the states that hopefully we can learn from actually is increased attention to equity and how to make sure that there's that populations who have been disproportionately impacted by the illegal market have equitable access to the legal retail market. A few thoughts.
And those are important. I mean, one of the questions that got raised is whether the illicit market in Canada is really a function of a homegrown market or diverted products from the United States, Canada, or Washington State. Is there an understanding of that or no?
All of the above. So, definitely seeing product coming in from the States. I haven't seen a lot of evidence for a large diverted market because the financial incentives aren't really there. A lot of it is just people who have an established relationship with the illegal market staying with their supply, and also the online market as well. So illegal online sales, and there's still, anecdotally and through small scale studies, seeing people who think that they're buying from a legal online source that is in fact an illegal source.
Yeah. So a question is being raised, Ricky, about whether a goal of cannabis legalization or regulation is really about improving the opioid problem and reducing opioid misuse, improving the effects of opioid use withdrawal, or should we also be concerned about cannabis withdrawal? To what extent are these competing concerns in a public health framework?
Yeah, I mean, from my perspective, the overall goal obviously wasn't to do anything to opiates and opiate users in general, right? I mean, I think there were other motivations for cannabis legalization. But since it's happened, let's, explore the possibilities. And I do think, again, for the population that I'm focused on, if they're using cannabis instead of opiates, that's great. If they're using cannabis to offset opiate withdrawals, great. If they happen to develop cannabis withdrawal symptoms later, that's better than having opiate withdrawal symptoms, because that's not to say that that's not a problem, but that
right.
it's you've moved someone out of an illicitly manufactured substance that's more potent, poorly regulated, and in an environment where it's often contaminated, not just with fentanyl, but other things. It's if we can move them to a better regulated substance, that from a public health perspective, I think we have to regard that as a win. And then I also recognize that relationship between cannabis and opiates is not well established. So you have studies that show, hey, it goes down, and you have other studies that say, hey, it goes up. And I do think part of, my take home is that I do wish that we had a little bit more regulation on what the cannabis was and how people were using it, so that we could be better able to understand what the opportunities are for some of these health benefits. And I feel like we're losing that, right? We're losing the incentives for that, and we're losing the interest in supporting that kind of activity as it moves fully into sort of this Wild West legalization.
Yeah, this hits on a point that is raised by Howard Padua at UCLA, who is saying, there's recent evidence that show that people who use opioids are also more likely to use cannabis when using opioids. And there's ongoing research to try to understand. We talk about cannabis as if it's a singular product. When they're using opioids, which version of cannabis are they using? Are they using a high potency product that allows them to offset issues of pain, in which case they might be mitigating their opioid use? Or are they using a completely different variant of cannabis to meet other needs, in which case they still are relying on opioids? We have a lot that we need to understand because cannabis is not a homogeneous product. And scientists, I think, are trying to address this issue, but there's a lot of work to be done because we are a little slow in getting out of the gate. Unfortunately, we are coming up on the hour, and we've been told we need to stop strictly at 12. So I would like to take a moment to thank both Rebecca and Ricky for your insightful comments. There's a lot of questions we were unable to get to, but we can keep those questions and post them on the Schaeffer website with responses so that we can provide responses for those that are interested. Thank you both for your participation. And I'd like to thank again Dr. Richard Merkin for his support of the webinar. And I'm sure we are going to be having more conversations going forward. Thank you all for joining us.